Mechanical ventilation is a dynamic partnership between a machine pushing air and a patient's own respiratory drive. If the machine's parameters fail to match the physical needs or efforts of the patient, the entire system collapses. To prevent that mismatch, we rely on a single two-part algorithmic question: who starts and what is controlled? The first half asks what triggers the breath. We have to define whether the inspiration is initiated entirely by the machine, completely by the patient, or a combination of both. The second half isolates the target variable. Once the breath begins, we must determine exactly what parameter the machine is responsible for maintaining. By applying this two-part test, we can systematically decode the four main modes of mechanical ventilation: CV or MV, CPAP, SIMV, and assist control. Mastering a ventilator requires looking past the abbreviations and rigorously defining who is doing the work at every single stage of the breathing cycle. We begin with control ventilator, or mechanical ventilator mode, often abbreviated as CV or MV. Applying the first half of our algorithm, the machine starts the breath. The patient has zero respiratory effort, typically because they are under general anesthesia or heavily sedated. The ventilator has full control. For the second half of the algorithm, we hit a hard physical limitation. A machine can control the specific volume of air entering the lungs, or it can control the pressure of that air. It cannot guarantee both at the same time. This table breaks down the resulting trade-off between volume control, or VCV, and pressure control, PCV. Looking at the VCV column, the machine makes a specific promise. It controls the tidal volume, ensuring a set amount of air is delivered on every breath. Because that volume is locked in, the required pressure will fluctuate based on the patient's lung compliance and airway resistance. Therefore, the primary clinical concern you must monitor is dangerous phi pressure. Shifting over to the PCV column, the logic flips. Here, the machine is set to control strict inspiratory pressure. The tidal volume is completely variable. Because the pressure is strictly capped, if the lungs become stiff or airways narrow, the actual volume of air delivered will drop. Your main concern becomes falling tidal volume. In mandatory ventilation, selecting what variable the machine controls directly dictates which physical danger you have to watch out for. At the complete opposite end of the spectrum is continuous positive assisted pressure, or CPAP. Applying our algorithm to who starts, the answer is strictly the patient. The patient must have their own respiratory drive. The device will not initiate a breath on its own. Think of a patient in CPAP as a balloon that is already inflating and deflating entirely under its own power. When we ask what is controlled, we find the ventilator provides zero mandatory breaths and does not dictate volume or peak inspiratory pressure. What the machine actually does is raise the baseline floor. It maintains a constant positive pressure throughout the entire spontaneous breathing cycle to keep the airways propped open. CPAP is not a breath delivery system. It acts as an internal structural splint for a patient who is already doing the respiratory work. Between the extremes of total machine control and total patient effort exist the hybrid modes, built for patients who can initiate some breaths but still require intervention. In semi-inspiratory mechanical ventilator mode, or SIM, the device initiates evenly spaced mandatory breaths, but the patient can take their own spontaneous, unassisted breaths in the gaps between them. Assist control, or AC, operates under a vastly different rule. In AC, every single breath gets full machine help, regardless of who starts it. This text block demonstrates how assist control processes patient triggers, using a set respiratory rate of 12 as an example. If the patient takes exactly 12 breaths, the ventilator satisfies that minimum requirement, providing full support for all 12. However, if the patient attempts to breathe faster, initiating 18 breaths, the machine reacts to every single trigger. It delivers full, mandatory level support for all 18 breaths. AC guarantees a minimum respiratory rate, yet because every patient-triggered effort commands a full mechanical breath, the actual volume of fully supported machine breaths will increase if the patient breathes faster. In assist control, spontaneous patient effort does not equate to independent breathing. It acts purely as a trigger switch that forces full mechanical intervention. Returning to our initial question allows us to map these modes entirely: who starts the breath, and what variable is controlled. We can plot these parameters onto a single matrix. The vertical axis measures who starts the breath, from machine to patient. The horizontal axis measures what is controlled, from baseline pressure up to full volume delivery. CV or MV sits squarely in the bottom right corner, entirely machine-started and fully machine-controlled. CPAP occupies the exact opposite position in the top left, entirely started by the patient, with the machine only controlling the baseline pressure. SIMV and AC sit in the middle of the spectrum, sharing the responsibility of who starts the breath, though assist control leans much closer to full machine control. A ventilator is a logic circuit that adheres strictly to the physical limits of the human airway and the specific inputs we program into it. By consistently identifying who starts the breath and exactly what is controlled, you predict the machine's behavior, anticipate the physical trade-offs in the lungs, and safely manage the patient's respiration.